Okay, so the question says International Contact Dermatitis Research Group advises first and second patch test readings to be taken in allergic contact dermatitis diagnosis at. So you must know that the interval has to be 2 days and 4 days. The interval has to be 2 days and 4 days. So with that, I hope you have understood that it is option C but not option B. Okay, so it is at 48 hours and 96 hours at which we are going to take the readings, the first reading and the second reading. Okay, so now let us look at a few important points related to the contact dermatitis. Okay, related to contact dermatitis, and I hope all of you know that contact dermatitis, it is of two types: irritant and allergic. So these are the two types, irritant and allergic contact dermatitis. So allergic contact dermatitis is the one which is going to be diagnosed with the help of patch test. So patch test is the investigation of choice for identification of ACD, that is allergic contact dermatitis. Very important, you must know. And there are various allergens which can cause this allergic contact dermatitis. So in metals, nickel is important, and in antibiotics, topical antibiotics, neomycin is important, and in the hair dye it is paraphenylene diamine, which is very important, and in the cement we have potassium dichromate. So all of these are allergens, and I hope all of you know that in parthenium, that is congress grass, in parthenium, sesquiterpene lactone is a very important allergen. So this is about ACD, a few allergens. Okay, so in the allergic contact dermatitis, I have told you already that patch testing is the investigation of choice. So what is this patch testing and what is the principle on which this patch test works? Very important, the principle on which this patch test works is to identify type 4 hypersensitivity reaction. Can anyone tell me what are the other names for type 4 hypersensitivity reaction? Yes, Dr. Roshan Mohanty. Can you tell me what is the other name for type 4 hypersensitivity reaction? Very important from your microbiology knowledge. I hope you know this. So I will give you a clue. It is also called as CMI, and we can also call it as DTH. So can you tell what CMI and DTH stand for? So it's not sun direct DTH which I am talking about. So CMI stands for cell mediated immunity. Okay, very important, cell mediated immunity. And DTH stands for delayed type hypersensitivity. Delayed type hypersensitivity. Delayed type of hypersensitivity. Very important. Other names of type 4 hypersensitivity reaction may also be mentioned in the question. So please make a note of this. And in this patch test, what is that we are actually going to do is, so you can see this is a hypoallergenic tape. This is a hypoallergenic tape which will consist of aluminum chambers. Which are called as pin chambers. Very important, this could be a potential MCQ in the future. These are called as pin chambers, and so inside these chambers we are going to fill the allergens. Like for example nickel, potassium permanganate, PPD. So we will fill these pin chambers, and you might be wondering how are we going to fill, where are we going to get these allergens. So don't worry, these are going to be available as pre-filled syringes. So we dermatologists buy these and keep them in the refrigerator, and whenever a patient query allergic contact dermatitis comes to us, then we are going to use these syringes and fill these chambers, and we will advise the patient that we have to stick these on the back of the patients, and the patient should avoid any contact with water, any sport which may lead to excessive sweating, and also avoid bathing. Okay, and for how much time the patient should avoid all this? For 2 days. Okay, for the first 2 days till which the patches will be there stuck over the back of the patient, so it is slightly uncomfortable for the patient, and also this is a costly investigation, which dermatologists usually charge somewhere around 2000 to 3000. Okay, and so you have to remember these time periods, very very important. This is not a simple test. Okay, this is a costly test. So the first reading will be taken at 2 days. At the time of 2 days, we are going to remove these tapes from the patient's back, and again we are going to call the patient back after uh, 2 more days, that is after 4 days of application of the patch. Initially we will call back the patient to check the findings which we can see over the patient's back. Okay, so these are going to be the findings. So you can see this and this area, whatever allergens are there. So don't worry, the patches are going to be numbered 1 2 3 4 5. So we will get to know which number is which allergen, so that we can identify what is the allergen which is going to cause any reaction. Okay, any kind of reaction. As you can see, other areas the skin is absolutely normal, but let us say for example this is 1 and this is let's say number 15. So these two are showing some reaction, and the reaction is graded. So these gradings are not very important for you. So basically plus, double plus and triple plus, so we are going to grade this like this. So if there is only erythema, we will say 1 plus. If there is some vesiculation seen, double plus. And if there is a lot of vesiculation, confluent vesicles if they are there, we are going to call it as plus 3. Okay, so this is how we can grade a patient according to the findings which we get. And one more very important question for all of you. So hi Richpal Galva, hi Anantamon ST. So one important question for all of you. So if in the options you get these two options, that is 2 days and 4 days, and you are asked which of these days is the best to identify allergic contact dermatitis, what is that you are going to mark in the exam? So please put your answer in the comment section. Whether you will opt for 2 days or whether you will opt for 4 days, which one is the best time to take the reading? Yes, so Anantmon says it is 4 days, and yes, Richpal, Roshan, what is the answer which you want to give? Please put it in the comment section. Yes, so okay, let us very good Sumajinok, very very good. So it is 4 days which is going to be the best reading. Why? Because it was observed that few patients might show a late reaction to allergen. That is the reason why taking reading on the 4th day, that is at 96 hours, is going to give us a best reading. Okay, and this is the next question. Please try to answer what are you going to put mark if this question comes in the exam. Okay, what is correct regarding patch testing? So please put your answer in the comment section, in the chat section. Yes friends, come on, I already have told the answer in the previous slides. So okay, Anantamon says all of the above is answer here. Okay, yes, Sumaya Junuk, Richpal Galva, Roshan Mohanty, I hope everyone agrees with this. Very very good, very good. So the majority students say that all of the above is the answer. Very good. So the patch testing is the investigation of choice in allergic contact dermatitis, and the basic principle which is it is going to identify is, yes, type 4 hypersensitivity reaction, which is also called as delayed type of hypersensitivity reaction, which is also called as cell mediated immunity. Very very important for you to know this. And as you can see, when I ask the same question, many students, by mistake, what we can say, by reflex, they have answered it as option A. They know that type 4 and also delayed type of hypersensitivity are also correct. So please, in the exam, whatever may be the exam, FMG or INICET or NEET, be very cautious while you are answering. Okay. And by the by, if you are not in a part of my Telegram group, Crack Derma with DrMSD, the links are there in the description. You can join my group. And yes, please try to answer this question. A patient presents with fever and joint pain for which she was put on NSAIDs. After 10 days, the patient has developed the following skin lesion. And what is that skin lesion which you must be focusing on? That is this hyperpigmentation which you are able to see over the nose. Now please try to answer this question. What do you feel is the correct answer for this question? Dr. Sumaya Jinok sir, I have question and you. Yes, thank you so much for that question, Sumaya Jinuk. Definitely in the future, I'm going to make a video, which will tell what is the difference between lentigo and freckle. Why? Because this was a previous FMGE question in which the multiple hyperpigmented lesions were shown in an image, and you are asked to identify whether it is a freckle or whether it is a lentigo. So this identification is very important. I will definitely make a video, and also I remember that you asked about hyperpigmented skin lesions, vitiligo, albinism. So also don't worry, I will make a video and I will post it in my YouTube channel. So I definitely make a note of all the feedbacks and also comments which the students are making. So don't worry, just put whatever comments you are having in the comment section. Very good. So the answer is chikungunya. And yes, very good, Anantmon. Yes, it is chicks. So for those students who are watching this video for the first time, this question, if you are watching for the first time, please remember, this is a very important question. So you can see AIIMS people are somehow in love with this question. They are repeating so many times. So there is every possibility it may even repeat again. So let us see the question carefully. In the question there are some clues. So the patient is having fever and joint pain. So for which she was started on NSAIDs, that is painkillers. Okay. Now after 10 days there is this kind of hyperpigmentation. So some students I know, they might feel that why not this is melasma. So let us see why not this is a melasma. This is not melasma because if it has to be melasma in the question, it will be mentioned most likely that she is a pregnant woman, and also there might be some mention that she is taking oral contraceptive pills, and also there will be some mention that she is exposed to sun very frequently, and most importantly in the MCQ or in the image it should be mentioned that the hyperpigmentation should also be present over the cheeks, and that too bilaterally symmetrical. So if all these were given, then we would have answered it as melasma, but because they are not given, so it is not melasma. And also many students have seen they marked fixed drug eruption as the answer, but it is not fixed drug eruption. Why? Because if it has to be fixed drug eruption, as you might see, be looking the clue which is given in the question NSAID. So this is the reason why FD will be marked as the answer by many students, but I will tell you why is it not FD. Because in the case of fixed drug eruption, the history will be given like what I am telling right now. So this patient is there who took NSAIDs previously, after which she developed some erythema. So initially in FD, fixed drug eruption, there will be erythema. Like for example, I am telling you as an example. So over the nose, she developed this erythema after NSAIDs intake previously in the past, and which healed with a hyperpigmentation. Now when again NSAIDs were given, again she developed erythema and which healed with hyperpigmentation. So if this type of history is given, then you have to mark FD, otherwise this is not going to be the answer. Okay, very important. And there are so many drugs which can cause fixed drug eruption, like for example NSAIDs, which usually cause FD lesions over the lips, and the Septran, that is cotrimoxazole, and tetracyclines. These are more commonly associated with genital mucosa, leading to fixed drug eruptions. And Sumaya, very good. So joint pain and fever, these are actually given in the question to tell that the patient is having chikungunya. Okay. So these are the important clues which are pointing out towards a possible chikungunya in the patient. And it was observed that in the patients who had this chikungunya initially have high fever, joint pains, no doubt, and I hope all of you know that crooked or bent joints is the other name for chikungunya. But the point which you must know is that in the skin lesions, the patient are going to present with morbilliform eruption. Almost 50 to 75% are going to develop morbilliform eruption. And not only that, it was observed that there is going to be a pigmentation of the face 2 weeks post fever. 2 weeks post fever, they are going to develop a pigmentation, and in various studies it was noted that this pigmentation which was seen in chikungunya patients, it was seen more commonly over the nose. So it was seen more commonly over the nose, as you can see in this is taken from a study. So in the pigmentation in chikungunya, it was observed nose was having this pigmentation so much common that it was given, in fact, named sign. It was given a name sign. It is called as chick sign. It is called as chick sign, which is seen post chikungunya fever. And as you can see the description, melasma like pigmentation, so that is brown or black macular lesion will be present over centrofacial face. It will not be bilaterally symmetrical, but it will be present over the centrofacial face. And now coming to melasma, so I have already told you that in the history there will be a mention of exposure to the sunlight, and also that the patient is going to be mentioned as a pregnant, or there will be some mention of oral contraceptive pills or phenytoin usage. So one question for all of you, so if melasma occurs in a pregnant woman, then it is given a special name. Can anyone tell me what is that other name of melasma if it occurs in pregnancy? So all those students who are watching this session, if if you feel that this session is helpful, please do give this video a thumbs up, guys. And also please try to tell what is the name for melasma if it occurs in pregnancy. Very good, it is called as cloasma. Very good, Anantmon, it is called as cloasma. This could also be an important question. And just remember that melasma, it is associated with hypothyroidism. Very, very important, melasma can be associated with hypothyroidism. Yes, now please try to answer this question. Topical steroids are most effective in. Very good, Sumay, you are also right. Topical steroids are most effective in which of the following conditions given in the options? So please try to select. Okay, Anantmon says option B is the answer, that is eczematous dermatitis. So others, what do you think is the answer? Please put in the chat section. Okay, eczema dermatitis. Yes, I got your answer, Anantmon. Okay, so one student says it is eczema, it is dermatitis, and yes, Sumay Junik and Richpal Galva and others who are watching this session. So, right, Anantman, your answer is absolutely right. So let us, try to first rule out the options, so it will become very easy. So these steroids, they are very, very notorious. If they are used for long term over the skin, they are going to inhibit the fibroblasts, thereby reduce collagen can occur, because of which dermal atrophy can occur as an adverse drug reaction. So definitely if it is adverse reaction, we are not going to use steroids in dermal atrophy. And if you look at option C, it is herpes simplex virus, that is a viral infection. And very, very important, in viral infections, steroids are contraindicated. Okay, we should not use steroids. Why? Because the viral infection may proliferate. Not only viral bacteria and also fungal infections, in these steroids are not routinely used. So option C is also ruled out. And acne rosacea, very, very important, friends. This acne rosacea can get triggered, and also it can get worsened if we use topical steroids. So in acne rosacea also We are not going to use topical steroids. So we are left out with eczematous dermatitis, and yes, Dr. Sumay Jinuk and Anantmon, both of you are right, very good. So in eczematous dermatitis, we are going to use topical steroid. And few points about eczematous eczema. So I hope all of you know that eczema is of three types: acute, subacute, and chronic. So these are the three forms in which eczema can present. So let me tell you few points about acute eczema, which is very very important. In acute eczema, the patient is going to have erythema will be there, lot of itching will be there. So that is redness will be there, itching will be there, itching, erythema will be there, and also there will be oozy skin lesions, that is oozing will be there, and also there can be edema, that is all the inflammatory changes will be there. And this oozing which we can see clinically, histopathologically we can identify this with one very important finding which you must remember, which was previously asked in the exam also. Can you tell me what is that histopathological finding which you can see in acute eczema? So I will give you options also. Do you want to call it as ballooning degeneration? Do you want to call it as acanthosis, or do you want to call it as spongiosis? Please put your answer in the chat, live chat. Okay, Anantmon says acanthosis. Okay, there I caught you, Anantmon. So yes, others also please listen. The options are ballooning degeneration, acanthosis, and spongiosis. So what do you want me to call this as? So I told you that oozing is there. That is, there is a fluid accumulation, and I will give one more clue. The fluid accumulation is present in between the cells. That is, intercellular fluid accumulation is there. Okay, come on, Sumay, Jinuk, Richpal. Okay, all the other students who are watching, try to guess what is the answer. Okay, so Anantmon, acanthosis, which you have told, is the answer for histopathological changes which we see in chronic eczema. Okay, so acanthosis is histopathological finding in chronic eczema, where there is going to be increased thickness of the stratum spinosum. Okay, very very important. And in the case of acute eczema, we are going to see what is called as spongiosis. Okay, very good. Okay, now you understood, and I hope you will remember this. Okay, spongiosis is basically intercellular fluid accumulation which can be seen in acute eczema. Very important. And what is ballooning degeneration? In ballooning degeneration, which can be seen in herpes simplex viral infection. Okay, Sumajinuk, no, ballooning degeneration is seen in herpes simplex viral infection, where there will be intracellular edema, intracellular fluid accumulation. So you can say these are the keratinocytes, and inside the keratinocytes, if there is a fluid accumulation, then we are going to call it as ballooning degeneration. Okay, Dr. Sumay Jinuk, no. Acute is not ballooning degeneration. Okay. So in viral infection with herpes simplex virus, herpes simplex viral infection, if it occurs, herpes simplex viral infection, if it occurs, there is going to be a fluid accumulation inside the cells. That is intracellular fluid accumulation. And this is called as ballooning degeneration. Okay. I hope now you understood, Sumay Jinuk. Please give me a thumbs up, everyone, if you have understood what I told you. Okay, now I hope I made this point very very clear. So ballooning degeneration, it is observed in viral infection, herpes simplex virus. This is also a very important question. And acanthosis, it is associated with chronic eczema, and spongiosis is associated with acute eczema. Okay, yes, please give me a thumbs up. Everybody please give me a thumbs up if you have understood and if you can remember this point. Sumajinic, I hope now you have got it clarified. And please remember, in acute eczema, we are going to use topical steroids. Topical steroids. Okay, very very important for you to remember what do you say? Yes, okay. Huh. Very very important for you to remember what are the important areas, important diseases in which we use topical steroids and important conditions which we should not use topical steroids. And one more point which I will tell you, in acute forms of eczema, we are going to use cream formulation. And in the case of chronic eczema also we will use topical steroids, but there the formulation is going to be ointment based. So this was a JIPMER question. Please make a note of this: cream formulation in acute forms of eczema and ointment formulation in the case of chronic eczema. So you can see here, acute forms of eczema, cream should be used. Chronic forms, we are going to use ointment based steroids. Now please try to answer this question in the poll. No, sorry, not in the poll, in the chat section, in the live chat. Okay, Anantmohan says option C is the answer. Yes, so if you look at the image, so the arrow is pointing out towards what? If you know this, then that is the first step, and then you have to know which cells are present in the area where the arrow is actually pointing. So first, let us get the orientation of this question. So if you look at this picture of histopathology, you should be in a position to identify that this is epidermis and this is the dermis. This is the dermis. And in the epidermis, I hope all of you know the layers from superficial to deep. That is stratum corneum, stratum granulosum, of course stratum lucidum will be there, stratum spinosum and stratum basal. So these are the layers from top to bottom. So all these layers will be there in the epidermis, and this is the dermis, and the arrow is pointing towards the structure. So these are the retail ridges which I marked with the blue color. And one second, yeah, so these I will use green color. So these are the dermal papillae. So the green color structure is the dermal papillae and the blue color structure are the retail ridges. So retail ridges and dermal papillae, they will be present alternating with each other, and you can see the arrow is pointing towards one of the retail ridge, and that too at the most basal layer of the epidermis, so it is trying to tell that it is stratum basal which I am pointing, and you need to identify which cell is not present in the stratum basal, and please remember keratinocytes, melanocytes and Merkel cells, all of these are present in the stratum basal, and it is Langerhans cell which is present in stratum spinosum but not stratum basal. And very good, Anantmohan and also Sumajani, both of you have answered it right. So Langerhans cells are present in stratum spinosum, but not stratum basal. Okay, so now let us look at few of the important basic concepts which you must know. So the order of the layers of the epidermis from top to bottom, I hope all of you know this mnemonic: come let's get sunburned. So very famous mnemonic. So stratum corneum, lucidum, granulosum, spinosum and basal. And one more thing which you must remember is stratum basal, it is also called as stratum germinativum. It is also called as stratum germinatum. Okay, so that is one point, and this concept I hope all of you know. This is epidermis and this is dermis, and the so skin is not just flat like epidermis is placed over dermis and some glue is put between both of them. No, it is going to be like this. So you can see dermis will throw some folds into the epidermis, and epidermis also will throw some folds into the dermis, and the folds which the epidermis throws into the dermis, because of which both of them get interlocked with each other. So the epidermal projections are called as rete ridges, so epidermal ridge or rete ridge, and dermal projections into the epidermis, they are called as dermal papilla. So you must know this concept. I hope all of you know this. Okay. Now coming to the cells of the epidermis and where from they are embryologically derived from. Very important. So the keratinocytes, they are the local cells. They are the local cells which are derived from the ectoderm, as the entire epidermis is derived from, and all the keratinocytes, they are going to form 85 to 90% of the cell population of the entire epidermis. And just remember that embryological derivation is a from address, and the ultimate area which these cells are there as to address. So from address and to address is there for all the cells of the epidermis, and you must remember 4 important cells in epidermis. So keratinocytes we have already seen, the from address is ectoderm, and the to address is all the layers of the epidermis, all the layers of epidermis. So in all the layers, keratinocytes will be there. So other cells are not like that. They have some specificity to where they have to be stayed. That is, they want a to address to be fixed. If you look at melanocytes, their from address is neural crest, but the final Aadhaar card permanent address is stratum basal. Okay, so it is stratum basal. And Merkel cells, the derivative, their from address is ectoderm. Very important. You have to remember that it is ectoderm from which Merkel cells are derived. But the to address, the final permanent address in Aadhaar card of Merkel cells is again same like melanocytes, it is stratum basal. And Langerhans cells, now this is something interesting. The from address is mesoderm. It is bone marrow. Why? Because Langerhans cells are the antigen presenting cells. They are the antigen presenting cells. So they are going to come and stay in the stratum spinosum. Stratum spinosum. Very important for you to remember all this. And in this picture, you can see in the stratum spinosum, the Langerhans cells are present. And these are antigen presenting cells. These are antigen presenting cells. Very important for you to remember. And in the stratum basal, you can see, so this is stratum basal, and you can see these are the keratinocytes. These are the keratinocytes which are making the most of the population of the epidermis everywhere in all the layers, and also they are present in the stratum basal also. And you can see melanocyte and Merkel cells are also present in the stratum basal. Okay, very important for you to identify this. So melanocytes and Merkel cells are there in the stratum basal. Few points about Langerhans cells. Why? Because these are very important for you to remember. You can see in this picture, this is a diagrammatic representation where you are able to see in the stratum spinosum the dendritic processes are present to this cell, and this is nothing but the Langerhans cell. So these are also called as dendritic cells, and these are basically antigen presenting cells. And these can be identified on electron microscopy with the help of these Birbeck granules, which are having this peculiar shape. So now, can anyone tell me what is the shape? What is this shape called as? Yes, please try to tell what is the name of this shape which is given to this Birbeck granules, which are present inside the Langerhans cells. Yes, Anantmon, they are called Birbeck granules. I am asking what is the shape of this. So you are able to see at one end there is oval shape, and at the other end we are having this a rod-like shape. So very good, Dr. Chowdhury. It is tennis racket shape. Very good. You have marked it right. You have answered it right. So it is called as tennis racket shape. And one more point about Langerhans cells, which is very important, is what is the most specific marker of Langerhans cells? What is the most specific marker for Langerhans cells? It is CD207, which is also called as Langerin. So this could also be a potential question. Very important for you to remember. Most specific marker of Langerhans cells is CD207 or Langerin. Yes, now please try to answer this question, which is very easy for you right now. Yes, yes, very good, Anant Mohan. You have marked it right. So it is ectoderm. It is ectoderm from which Merkel cells will come. And not only Merkel cells but also keratinocytes are also ectodermal in origin. Ectodermal in origin. Okay, so very important. And from neural crest, what is the structure which you are going to get? Yes, anybody? So from neural crest, what are we going to get? Yes, anybody? Yes, right. Very good. So from neural crest, we are going to get melanocytes. Melanocytes. Very good. And from mesoderm, what are we going to get? So we have seen in the previous question itself. So from the mesoderm, that is from the bone marrow, we are going to get Langerhans cells. So very important. All these origins, embryological derivations to be remembered. And yes, okay, now let us look at the next question. Yes, now please try to attempt this question. Probably this is one of the slightly difficult questions in this session, we can say. So I will give you 1 minute. Please try to mark what is the answer. So these are the options, which is that order from superficial to deep. Which one do you think is the answer for this? Yes. Anantmon says option B is the answer. Okay. Rest. Dr. Dashrath Bhai. Yes. What do you think is the answer for this question? And also, gentle reminder, if you have not liked this YouTube video yet, please do give this video a like, friends. Okay, so all of you agree with option B, which Anantmon says, or do you want to disagree? So the time is up. Okay, so Dashrath disagrees. Very good. So okay, so with resistance, with friction only, you can learn and remember things. Okay, so now let me tell you. So one student says option A and one student says option B. So 50-50%. So let us look at these disorders. So briefly, we'll get a brief about these disorders. So as you can see, vesiculobullous disorders, VBD stands for vesiculobullous disorders, and divided into immunobullous disorders. I stands for immuno. MBDs, that is mechanobullous disorders, and finally inherited acantholytic disorders. Okay, so in the immunobullous disorders, we have various examples, like for example, pemphigus vulgaris, bullous pemphigoid, dermatitis herpetiformis, linear IgA bullous disease, and what else? Yeah, pemphigoid gestationalis. Okay, so these are the important ones which you must remember. And in the mechanobullous disorders, you must remember one very important point, that these are all genetically inherited conditions. That is one point which you must remember. And the other point is the names of these disorders. These are called as epidermolysis bullosa. So epidermolysis bullosa, simplex, junctional, and dystrophica. So all these are examples for mechanobullous disorders. All these are examples for mechanobullous disorder, and these are all genetic conditions. Why am I telling you this point is, in the exam I have seen that epidermolysis bullosa, simplex, junctional, dystrophica were given, and you were asked what will be the DIF finding in these diseases. So please remember, these are all genetic disorders. So in the DIF there will not be any fluorescence. There will not be any fluorescence, and it is going to be a negative DIF finding. So DF will be negative. Very, very important for you to remember in all these conditions, DF will be negative. Why? Because direct immunofluorescence is going to identify some form of autoantibodies, and autoantibodies are present in immunobullous disorders. Okay, so that is one general thing which you must remember. In inherited acantholytic disorders, Haley disease is there. And we have Darius disease, but not very important. So if in the future videos we have related topics, we will discuss about them. So in the immunobullous disorders, depending upon level where the split is seen, depending upon the level, we have intraepidermal blistering disorders or we have subepidermal blistering disorders. Intraepidermal or subepidermal blistering disorder. So very, very important for you to remember, intraepidermal blistering disorder, Pemphigus group of disorders belong to this intraepidermal blistering disorders, and in the subepidermal blistering disorders we have bullous pemphigoid, and dermatitis herpetiformis, which are very, very important. Very, very important. And now let us see this very important dermoepidermal junction, which if you can understand, you can get to know what is the answer for this question. So first get the orientation of this picture. So this is basically a keratinocyte. So that is one thing which you must understand. And in the which is the layer in which we are seeing this keratinocyte? This is stratum basale. That is the deepermost layer of the epidermis. So in this we are looking at the stratum basal keratinocyte. Okay, and you are able to see these black colored filaments. These are basically keratin filaments. And in the stratum basal we have keratin 5 and keratin 14 heterodimers. Okay, and also you are able to see this black colored block, which you are able to see. This is very, very important. This is hemidesmosome. And you must remember that hemidesmosome is again having two parts. So the the cell has a inner block, and outside the cell we have a outer block. So in the inner block we have what is called as BPAG1, and also we have plectin. So these are the proteins which are present in the inner block. These are basically components of hemidesmos. And in the outer block we have BPAG2 and integrin. Okay, so this is about hemidesmosome, which helps in connecting the stratum basal to the underlying dermis. So below this we have the dermis, but please remember, in between the epidermis and dermis, this portion is very, very crucial in connecting the epidermis with the dermis. So this portion is called as basement membrane zone, or this is also called as dermoepidermal junction. So there are two names for this specialized zone. It is called as basement membrane zone, it is called as dermoepidermal junction. So in this we have few other sub components which you must remember, and one among them is, I will use a separate color, it is lamina lucida. And the important protein which is present in lamina lucida is laminin. And the next layer it is called as lamina densa. And the most important protein which is present in this layer is collagen 4. And now coming to the next layer, it is called as, it is present below the lamina densa, so it is called as sublamina densa. And in sublamina densa we have the protein that is collagen 7, which is also called as anchoring fibrils. Okay, why are we discussing all this? Is because different vesiculobullous disorders have defects in different proteins. So as you can see, keratin 5 and keratin 14, these are defective from the birth genetically in epidermolysis bullosa simplex. Epidermolysis bullosa simplex. Okay. Whereas if you look at the collagen 7, that is anchoring fibrils, these are going to have auto antibodies in epidermolysis bullosa acquisita, and the collagen 7 is genetically defective in epidermolysis bullosa dystrophica. Okay, I think I am coming in the way. So epidermolysis bullosa acquisita will have auto antibodies against collagen 7, and in epidermolysis bullosa dystrophica the collagen 7 is going to be genetically defective. Okay, so that is about epidermolysis bullosa. Now we are left out with the hemidesmosomes, lamina lucida and lamina densa. So please remember, in the given question you can see that we have this bullous pemphigoid and linear IgA disease. So you must remember this, that in bullous pemphigoid the BPAG2, bullous pemphigoid antigen 2 and bullous pemphigoid antigen 1, both of these are going to have auto antibodies. And in the case of linear IgA disease, you must remember that BPAG2 no doubt has auto antibodies, but apart from this, it was observed that collagen 7 is present in the sublaminar densa, and this also has auto antibodies in linear IgA disease. I will show you in the upcoming slides. So if you look at other options, pemphigus vulgaris, I told you that this is an example of intraepidermal blistering disorder, and I want all of you to answer one question. So in pemphigus vulgaris, what are the antigens against which antibodies are produced? So this is my question. Please put your answer in the chat section. So I will give you a clue. The antibodies are produced against desmosomes, and these desmosomes are again made up of certain proteins. So please tell me what are those proteins, and in pemphigus vulgaris, what is that most important protein against which antibodies are produced? Yes, come on friends, please tell me what is that. So I will give you one more clue. They are called as desmoglins. So please tell me. Very good, Anantmon, you have come up with the answer. So very good. Desmoglin 3 more than desmoglin 1. So these are the antigens against which auto antibodies are produced in pemphigus vulgaris. And you must remember that desmosomes, they will help in connecting two keratinocytes with one another. So this is the intraepidermal blistering disorder, epidermal blistering disorder. So definitely option 1 has to be the first option among the given options. Okay, so now with that we can rule out option C and option D, and option 1, that is pemphigus vulgaris, has to be the most superficial one. And if you look at the other options, the last option, epidermolysis bullosa dystrophica, if you remember, I told you that collagen 7 which is present in the sublaminar densa is going to be genetically defective. So this is going to be the most deeper one, and you can see option A and B both are having option 4 as the last one. So now the confusion comes with the two entry, that is linear IgA disease and bullous pemphigoid. And as you can see, I told you that collagen 7 is also going to have autoantibodies in linear IgA disease. Because of this, what we have to mark here as the answer is option B. Option B is going to become the answer here. Sir, epidermolysis bullosa simplex is defective K5 and K14. Yes, so I have told this already. So you can see here epidermolysis bullosa simplex, it is K5 and K14 which are defective. And that is the reason why epidermolysis bullosa simplex, it is an example of an intraepidermal blistering disorder. Okay, please remember this point. Okay, and in this question, so you can see that after pemphigus vulgaris, I will show you the picture here. So in the pemphigus vulgaris, So in the pemphigus vulgaris, keratinocytes are going to have a defect. Keratinocytes are going to have a defect. So pemphigus vulgaris, we will keep it at most superficial. Where should I draw this now? Yeah, here I will draw. Okay, pemphigus vulgaris, because it is intraepidermal blistering disorder, that is going to be the superficial most blistering disorder, superficial most. The next one is going to be bullous pemphigoid, where there is going to be a defect in the bullous pemphigoid antigen 2 more than bullous pemphigoid antigen 1. So more deeper, we have linear IgA disease. Why? Because definitely this has autoantibodies against BPIG2, but also it has autoantibodies against collagen 7. So as you can see, these are the studies. The links I will try to put in the description. Okay, you can check them out. Sublaminar densa type of linear IgA bullous dermatosis. This is new thing which is being discussed a lot. So in this, it was observed that IgA autoantibodies specific for type 7 collagen are being identified. Okay, so that is the reason why we are putting that. And finally, we have epidermal bullosa dystrophica, in which we have pure defect genetically of collagen 7. And this is another study you can see from JAMA from 2021. Sir, is the linear IgA and IgA? So IgA pemphigus is completely different condition. Okay, don't confuse linear IgA bullous dermatosis (LABD), which is also called as chronic bullous disorder of childhood, with IgA pemphigus. IgA pemphigus is a type, it is a variant of pemphigus. Okay, in which IgA is going to get deposited in a fishnet pattern intraepidermally. Okay, fishnet pattern of deposition will be there, but unlike pemphigus vulgaris, in the IgA pemphigus there will be IgA deposition in a fishnet pattern. Okay, that is very important point which you must remember. I hope now you have understood this. Anantman, please give me a thumbs up if everyone has understood this point which I told. And I hope all of you know this concept of salt split technique, which is used in indirect immunofluorescence in vesiculobullous disorders. So in this, we will put the skin sample in 1 molar solution of NaCl, because of which the lamina lucida, which is very fragile. So 1 second, what is this? Yeah, so the lamina lucida, which is the most fragile zone, it will get separated. And then if we perform this immunofluorescence, indirect immunofluorescence, we can identify either the fluorescence will be present over the roof, or it will be present over the floor. Okay, so in the case of you can see the bullous pemphigoid, the fluorescence is going to be on the epidermal side, that is, we can say, on the roof side. And in the linear IgA dermatosis, you can see that it is of two types, lamina lucida type, and there is one more type called as sublaminar densa type. So in the lamina lucida type, where mainly the BPAG2 is the auto antibodies which are produced, so the roof is going to show the fluorescence, whereas in the case of sublaminar densa type, we are going to see a fluorescence precisely on the floor of this salt split skin. Okay, so with this you can see that linear IgA bullous dermatosis can be of these two types. Okay, I hope you have understood this. And yeah, these are some of the points. These are some of the images of the basement membrane zone, and you can just pause this. And these are the topics which are going to discuss in November 2019. So I hope this video was helpful for the students who wanted to see the discussion part of the